Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help. Good morning, Thursday, April 30th. Thanks for listening to Wild Health and the COVID-19 update. As of yesterday evening, Worldometer reported approximately 1,049,000 cases and 60,600 deaths in the United States, and approximately 3.2 million cases and 226,000 deaths worldwide. Data from the Financial Times shows that daily new coronavirus cases and deaths in the United States continue to plateau, and the rate of increase in new cases may even be falling. In fact, the rate of new cases is slowing down in most countries that had earlier outbreaks, particularly in Europe. Meanwhile, outbreaks continue to grow in Russia, Turkey, Brazil, and India. In the U.S., the New York Times reports that the FDA will likely announce an emergency use authorization for Remdesivir, an antiviral drug to be used in the treatment of COVID-19. We've been talking about that drug for a while. It seemed very promising. And in his White House briefing this morning, Dr. Anthony Fauci, the government's leading infectious disease expert, discussed promising early results from an ongoing NIH clinical trial, which shows that Remdesivir may accelerate recovery from advanced COVID-19. Oxford University has risen to the forefront of the worldwide race to find a coronavirus vaccine. Scientists at the university's Jenner Institute announced that their vaccine has already shown promising results in lab animals, and they'll be moving on to clinical trials on over 6,000 people. If the vaccine proves to be safe, the first few million doses may be available by September, which is months ahead of any other vaccines currently under development and quite a ways quicker than we initially were thinking. I think we should probably temper expectations a little bit, saying there's a lot of ifs in between there, and they talk about the first few million doses. So that does not necessarily mean return to concerts and sporting events. So we will need millions of doses just for healthcare workers and those at high risk. So we're still, at best case scenario, still looking to be a little ways out from the general population having a vaccine that's safe and effective.
Yeah, apparently the Jenner Institute was working on vaccines for other coronaviruses. So they were able to use some of those vaccines to kind of bypass that initial safety test. So the stage 1 testing, where you're just testing to see if, there's significant side effects from the vaccine. So they were able to bypass that, go straight to the monkeys. They've now shown that I think it was 6 monkeys that they gave the vaccine to were able to tolerate very high doses of viral titers and still haven't shown any infections in 28 days. So encouraging, but we still need to see that data translated into humans, which is obviously the stage 3 of the clinical trial.
Yeah, I remember we were talking to Dr. Bright about this probably a month or two ago and said, what is our best hope for getting a vaccine this year? And his answer was luck. So hopefully this is that luck, and we'll continue to have luck with this vaccine and everything will go really well with it.
Matt, you were also talking about the NIH data on remdesivir. I was able to track that down. So, as you mentioned, Fauci was basically saying that there's some promising early results. So the question is, what are those early results? Well, it turns out the preliminary results are showing that basically patients who received remdesivir had about a 31% faster time to recovery than people who got a placebo version. The median time for recovery was 11 days for patients who were treated with remdesivir, as opposed to 15 days for the people who got the placebo. They also noticed a survival benefit, mortality rate of 8% for the remdesivir group versus 11.6% for the placebo group. Unfortunately, the p-value for that was 0.059. So trend towards benefit. Obviously, more data to come on that. Preliminary results are positive. Not a slam dunk by any means. This isn't going to be the treatment that cures people immediately, but it could certainly reduce the severity of illness and the duration of illness, which is better than anything else we have at this point.
Yeah, and I guess a few thoughts on that. You may see, actually, this could be reported as remdesivir fails, because if their primary outcome was mortality, they're looking for a survival benefit, then technically by standards of studies, it doesn't meet statistical significance because there isn't a p-value of less than 0.05. However, it does seem that there's definitely a suggestion of a benefit and a nice trend there, 8 versus 11.6%. So it seems like they probably just needed a bigger N, like more people in the study, and it would be statistically significant. So it's very encouraging results. And I'll tell you what I'm most excited about is just that you actually use the word placebo when talking about a study on
it's
COVID-19.
A word that hasn't been used recently.
It's so exciting to see that there actually was a placebo used, and it's a real study. So if you see that reported as remdesivir failed, I mean, that could actually be the conclusion if you have the null hypothesis of if you're just looking for survival benefit and mortality. But just know that this was a very positive study, and it's very encouraging.
I think they're probably going to report it as time to recovery as opposed to mortality. I think mortality is going to end up being a secondary finding. But in any case, it looks like the data is going to be positive. So that's good news. Another study, or not a study rather, but another recent finding that was reported in the news with regard to a possible coronavirus cure is out of Mount Sinai Hospital in New York, where doctors are evaluating the use of stem cell therapy as a possible treatment in COVID-19 patients. Apparently, they gave this to about 12 patients. 10 out of the 12 coronavirus patients were able to come off the ventilators shortly after receiving the stem cell therapy. In some cases, they mentioned that the therapy seemed to improve the patient's parameters within a matter of hours. They are very quick to say that they don't really understand exactly why this is happening. So we don't understand any pathophysiology of why stem cells would potentially help prevent or improve recovery from COVID-19, but this has been observed, and next step is to perform a study and look a little bit deeper into it and see if we can find anything. So look for that to be coming out soon.
Yeah, this is a report. It's not a study, and you notice Mike did not use the word placebo anywhere in this report. So we don't know what it means, but it's encouraging. It's worth noting. And my favorite thing about what you said there is that someone is actually going to be doing a trial, so a 300-person trial. So hopefully we will get the answer to this question. But this is just kind of some encouraging news to talk about. We at the summit that we held a few weeks ago, we did have a specific topic where we talked about stem cells and its potential role. Dr. Tim Mosley, PhD, gave that talk. So we're going to be releasing that tomorrow. So if you're interested in this, listen in, but definitely more data needed, but kind of some exciting news there.
Last study I want to talk about is not necessarily anything groundbreaking, but it is important and I think worth mentioning. This was reported in Nature on April 27th. The study is aerodynamic analysis of SARS-CoV-2 in 2 Wuhan hospitals. They looked at the concentration of the virus CoV-2 RNA in aerosols that they got from different places in the hospital, basically 2 different hospitals. And they found that it was moderately elevated in patient rooms, especially in the ICU, but at a fairly low level. But in the toilets, it was fairly high. So much higher amount of virus in the toilets than anywhere else. I'm laughing a little bit because you and I had a sort of a back and forth joke about this during the during the webinar that we did on this, or the Wild Health Summit. So more data to suggest that you should probably be wearing the respirator into a public bathroom.
Or at least put the seat down, but put the seat down before you flush.
If it's got a cover, definitely put the seat down. Yeah, I'm starting to think maybe we need negative pressure bathrooms. They also found fairly high levels in some of the medical staff areas. What's important to note here is that they retested the areas after implementing rigorous sanitation procedures and found that after they performed these sanitation procedures, it was fairly minimal in terms of the detectable levels. They actually went through and looked at different rooms of the hospital and even outside of the hospital and in department stores around the area for different levels of the virus. They found that it was highest basically in the ICU rooms, in the toilets, as we mentioned, in the changing rooms for the physicians, so where they were donning and doffing their PPE, in the med staff rooms, and then interestingly in a department store nearby. So the important thing to remember here is that we don't know whether the presence of RNA particles in aerosols in a hospital are necessarily contagious. We suspect that they probably are. It's been wildly described that this virus can potentially be transmitted through aerosols. So I think with its presence in the aerosols, we should consider it contagious until proven otherwise. But this is just more data to suggest that we need to be really careful about our PPE in multiple areas throughout the hospital, not just in the rooms where we're caring for patients.
When you were just talking about this aerosolization being described, I couldn't tell if you said wildly described or widely described, but I think either actually applies because it's pretty wild and scary to think about this being aerosolized. So, I mean, to me, the take-home point of this is until the pandemic is over, we just don't breathe. I mean, you better safe than sorry, I guess.
Just stop now. Yep.
Yeah. No. So I do want to talk about one more thing. Which is something we've been talking about recently, but not on the podcast, as we've been working with groups to talk about how we reopen and return to work or return to sport. Something that's came up, we were talking to a group the other day and had this idea, and then we ran it by our lab director, and he said, absolutely, we could do that. And then we looked it up, and there actually are a couple studies showing that it can be done, one out of Stanford and then one out of another group as well. But the idea just uses some simple math, and it's called pooled testing. So this only works if the prevalence is low enough in the group that you're testing, but you could potentially save quite a bit of money because it could get expensive if you're going to be testing a large group. For example, I'm going to use a few examples because these are real examples of groups that I've kind of talked to and given these examples to. So the first group, for example, let's say we have a really low prevalence, like 0.5%, which is the prevalence in a lot of places. Some places it may be even lower, but that's 1 out of every 200 people infected. So say you have a 9,000 person plant that you want to put back to work, or you have a 9,000 person event, like a large cycling event or something like that you want to go. If it's 1 in 200 people have this, then what you can do with this pool testing, instead of testing all 9,000 people, running them through the reverse transcriptase PCR test, which may cost Medicare reimbursements about $100 on that. So that would be pretty expensive to do. Well, instead, let's say you take those 9,000 people and you divide them up into groups of 30, and then you swab all 30 people. You put those 30 into one PCR test. You mix up the viral transport medium, and you run 300 tests instead of 9,000. So you have 30 groups there. On average, you're going to have 45 positives if you have a 0.5% prevalence. So on 45 positives, you just ran 300 groups of tests. Worst case scenario, you're going to have 45 groups out of those 300 that test positive. Now, if there are 2 or 3 people in one group, you're going to have less than 45 total groups. But if you have 45 total groups of 30, that's 1,350 patients left. So you have just eliminated almost 8,000 people you've screened out with one round of 300 tests. So then you have 1,350 people. So let's say you divide those up into groups of 4 to 5, much smaller groups, and then you test 300 more. because that would be another 300 tests. Well, if you have 300 tests, then worst case scenario at that point, 45 out of those 300 groups test positive again. So now you're down to 45 groups of 4 or 5. So you're down to 180 people. So then you just test all 180 of those people, because if 45 out of those 180 are positive, now you have a much higher prevalence. So what you've done is ran 300 tests that are pulled, 300 more tests that are pulled, and then 180 tests to identify exactly which 45 people are positive on average. So you've ran 780 tests instead of 9,000 tests. So a massive savings in cost. You're doing 1/10 of the cost approximately to test all of those people. A couple other examples that we're talking about. Let's say you only have 300 people you need to test, but it's a slightly higher prevalence, 1% of the population. So on average, 3 of those people. Well, a reverse transcriptase PCR machine, certain ones, one that we use specifically, I know you can run about 30 tests at a time, just the number of wells that are in it. So let's say you divide that 300-person group into 30 groups of 10. So you swab 10, then you're running 30 tests. So if 3 people have it, you're going to get 3 of those groups that test positive. Well, 3 times 10, that's 30 people. So then you just test all 30 of those people. And in 2 rounds of testing, pretty quick and easy, you've ran 60 tests instead of 300 tests, and you've identified exactly the 3 people that are positive. And then I want to give one last example, because it's a slightly different scenario, because we were talking about the PCR CDC test running. So one example we gave in the return to sport or work scenario is an NFL game. So a football game where you really cannot miss one of these players. They're ramming up against each other for several hours, and you got to make sure they're all tested. Let's say all you had was a Cepheid machine that could only test 4 samples at a time. And on average, in an NFL game, about 90 players get in. So we use the number 96 to round up, and because it's divisible by 4. So if you divide those 96 players into 4 groups, because you can only run 4 tests at a time, you've got 24 players in each group. So let's say an even higher prevalence. Let's say 2% of the population, because these are denser areas. We don't have any rural football teams. So let's say 2%. So if it's 2%, you divide them up into groups of 4. You're running 24 per group. And the first test, you're going to have 2 positives. So 2 out of those 4 tests that you run, 2 of the groups are going to be positive. You may get lucky and both may be in the same group, in which case you would eliminate 72 of the 96 immediately. But if you didn't get lucky, worst case scenario, you've eliminated half. 48 of the players are negative, and the other 48 still have to be tested. So then you divide those into 4, and you test them again. So worst case scenario each time, if the 2 players are in the different groups every single time you test, worst case scenario is you do 6 rounds of testing. Now that may sound like a lot, but this test is ran in 45 minutes. So you could do this in 6 hours, doing a total of only 24 tests. And you could do this without a full lab. So you have a Cepheid machine that can run 4 at a time. So you could do this in 6 hours. And like we talked about at the Return to Work seminar, you'd like to kind of Swiss cheese layer this and potentially do multiple tests, because the sensitivity isn't perfect. So if you can do it in 6 hours, then you could technically do this twice the day before the game and once the day of the game. And then you've got an exceedingly low chance of a false positive if you've layered on top of each other like that. So hopefully that math made sense. I think those were pretty straightforward examples. There's a lot more math we can get into. I mean, if you really want to maximize efficiency and run the least samples possible, there is some math around that. If you wanted the expected you could take the expected frequency of positive samples, P, and calculate the initial batch size that yields as close to 50% positive rate. There's an equation for doing that, and you could figure out exactly what size groups based on the prevalence that you should run to do the minimum number of tests. But it'll probably depend more on how many tests at a time you can run efficiently and the groups of people and where they are, because you could do this even better by grouping the players or grouping the workers according to the areas they work in and play in and where there's more contact, because then you could get lucky and have multiple positives in one group, so you're ruling people out more quickly.
That's one thing that you mentioned earlier, Matt, that I didn't know if you were going to mention that is also, I think, really genius. I mean, let me just first say that this is probably the most interesting thing that you've said in at least 45 days. I think this idea of pooled testing is pretty genius. Not just for the cost savings, which you already mentioned. I mean, you're talking like upwards of 93% cost savings. I mean, that's amazing. The difference in total cost. When you're talking about a test that can cost anywhere from $100 to $150, per test, and you're talking about testing a 9,000 person plant, that is an overwhelming cost. But now you've decreased that by 90%, and maybe even more importantly, you've decreased the amount of time for testing, right? I mean, you can imagine how long it would take to test 9,000 people, especially, if you don't have access to just a ginormous lab, right? And most people don't have access to that right now. So, I mean, testing's hard to find at all. So the idea of decreasing the burden and the timing of testing, you could get that first batch back, like you mentioned, from the 9,000 person event or 9,000 person plant or whatever it is. And you mentioned after the first batch, 8,000 people are free. Now you can send those people to work, send them off to the event, get them going, get their doing their thing, even just from that single first batch. If you were testing each person by person, that would take you days to get those numbers. So it's pretty awesome idea.
Yeah, and if you want to really save time and money, you could even use the same swab for every single person as you're kind of going down. No, I'm just kidding. I'm totally joking. Don't do that. There are. How explicit should we be that we were just joking there, just to make sure no one does?
I think you probably need to say it one more time.
Okay, yeah, just joking.
Do not do that.
But there are definitely caveats to this. There's logistical issues. Is there some dilutional effect when you do this? So there's a couple papers on this. If you're interested, you can read it. And again, the prevalence matters. So you can't do this if, for example, like in New York City, if the prevalence is 20, 25%, then this simply doesn't work. Because if you divide people up into groups of 10 and 25% of people are going to test positive, then every group is going to test positive. So you're not really saving any time. So this has to be in a low prevalence situation, and the prevalence will kind of make up how big of the groups. And there are just physical limits on mixing this and how you do it. So there's lots of issues with this, but I get really excited when I see math that really helps solve a big problem like this. So I hope that more people start doing this. We are advising groups on how to do this now. We're happy to help you. If you want us to, reach out to us, maybe Instagram or Facebook. Mike, do you check Instagram at all at Wild Health MD, or should we just say email? Is that better?
I check it every day, but email is probably the safer way to go about it.
Well, Matthew.Dawson@wildhealth.com. You feel free to email me, and I'm happy to share information on these protocols as well. And tomorrow, we're going to be talking about stem cell therapy with Dr. Tim Mosley. Thanks for listening.
Thanks so much for listening to this COVID-19 update. Please send us your questions or follow along on Instagram and Facebook at Wild Health MD. And just to be clear, this is not medical advice. No patient-physician relationship has been established, and this resource is really for general informational purposes only. And finally, if you want to spread the word, please send this podcast to friends and family and give us a review on iTunes. Thanks again, and stay safe.